And good morning. It is now March 30th,
Yes.
2023. We are broadcasting from Duke Spine Institute live spine surgery. Our patient comes to us with a history of lower back pain and weakness in the legs from pinched nerves, herniations. He has herniations at L1-2, L2-3, and L3-4, L4-5. He also has a spondylolisthesis or slippage of the bones at L4-5, which we'll see shortly with the X-ray. We are using our new fluoro machines, top of the line from Siemens. Blood pressure is good.
Just check it right now. I just gave this first. It's 137.
All right.
I just gave him a shot.
Yep, it's fine. All right, so we're going to get started. You can see on the X-ray. Let's go ahead and come south for just a moment, and we'll do a shot. And there's definitely no patient name being shown, right?
Of course.
All right. So let's take a look. There's the sacrum with the white arrow. You guys see that down there, sacrum?
Yes,
Then
we
we
do.
have a disc space. That's the L5S1, which is normal. And then we go to L5, bone. And now look at L4. And look at the back of L4. It's slipping forward on L5. We call that spondylolisthesis, slippage. Spondylo is spine, listhesis is slip. This would be an anterolisthesis. Antero is anterior, anterior is forward. That L4 is slipping forward on the L5 below. So we call that L4 anterolisthesis on L5. That's the terminology. Now, many spine surgeons, and including myself, if I didn't have the endoscopic Duke laser disc repair procedure, I would be doing a fusion on this patient. And most surgeons would do fusions, and it's a big debate right now, to fuse or not to fuse a spondylolisthesis. And it's a mixture of opinions. Some do, some don't. In the end, we don't need to fuse because we're not going to be removing the spinous processes, which other doctors do, to do a laminectomy. Show us the lamina. Stay on the X-ray, please, and show us the lamina. You see the white arrow? So come down a little bit, right there. That down to there, further, right to the top of the pedicle. From there to there, bottom of the pedicle above to the top of the pedicle, but that's the lamina. So laminectomy, the doctor's removing that. But to get there, they have to take your muscles out in the back of your spine, back there, the filet mignons. So whenever you get a laminectomy, you're getting a big ugly scar, but that's not even the beginning of it. That's the tip of the iceberg, because below the skin, there's a massive damage being done by the surgeon to your normal spine, removing your lamina. And by removing the posterior elements, lamina, part of your facet joint, your interspinous ligaments, and your ligamentum flavum, removing those structures destabilizes the spine even more. And that's why fusion is being recommended. Are we ready to go? BP, can we get a little better?
Just gave him another dose. It's better now.
All right, I'm going to wait a minute. We're waiting for the blood pressure to come down. So this patient has 4 discs that are damaged. And, should I wait a little longer or are we good?
It's just insufflating right now.
Got it, got it. We're going to go in and fix 2 on the left, 2 on the right, because they're pinching the nerves going in his legs, causing weakness and numbness. We call that radiculopathy. We do a little more?
Yeah, give him some more.
All right. I like the blood pressure to be down around 110 systolic, and currently we're around 140. So we're going to give a little more medicine to get his blood pressure down. We're no epi, right, guys?
No epi.
Are we using epi at all in any of our procedures now?
No.
Wow.
Only if he's holding like a spinal cord stimulator and all that stuff.
Yeah. Let's save some money on the epinephrine. How much does the epinephrine cost?
Sarah, I mean,
It's pretty pricey and it's been hard to get, so it's
Short supply.
shortage, yeah. So
What kind of pricey are we talking? How much is an ampule?
usually comes in a box of 25. It's like anywhere from like 2 to 300.
200 to 300 bucks for 25.
But a box of lidocaine is much like just plain is much cheaper.
So we're talking about $8 a vial. Yeah, about $8 a vial.
Yeah.
$8 to $10.
Pricey
Yeah, I understand, but it's good to know the pricing. All right, well, let's go ahead and take any questions from the audience that we might have while we're waiting for the blood pressure to come down a little bit.
No current questions.
All right, let's go ahead and show a video of how is it that a herniated disc in your back can actually cause back pain.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
Okay, welcome back. We're just waiting a few more minutes till we get the blood pressure. Either we're not sure if it's under better control or if we just need to check it with another blood pressure cuff. So we're checking a different blood pressure cuff just to see if that could be the reason that we're getting the same blood pressure reading every single time, despite treating the patient for blood pressure being mildly elevated. All right. So while we're waiting, we're talking about some equipment. We just bought a Wilson frame. Luis and I are talking about when to use it. The Wilson frame is it's like a padded cushion device that is put on top of the operating room table. The patient lays on it on their belly, and it causes their spine to kind of kink forward instead of backwards. If you're doing a deformity surgery and you're fusing somebody, you're going to want them curving backwards, not forward. So you would never use it, though some surgeons are stupid enough to use it. They really make the mistake of using it for fusions. And you're not supposed to use it for fusions because it puts the spine in the wrong configuration, bending forward instead of bending backwards. So you always want the lumbar spine bending backwards when you fuse into lordosis. So it's a device that's been around for 50, 60 years, and it gets the pressure off the abdomen so there's no venous bleeding, or it minimizes the venous bleeding during the surgery on the lumbar spine by getting the abdominal pressure out, because there's a gap between the pads and the belly sags in there, just like with the Jackson table. Same thing, but the Jackson's even better at getting the pressure off the abdomen and reducing bleeding during surgery. Anyway, the Wilson frame is very helpful for surgeons. It's kind of like training wheels on a bicycle. It opens up the interlaminar space. It opens up the foramen. It makes it easier for the surgeon to get in there and do their surgery. But good surgeons don't need it, and we don't use it typically. But we're going to start using it for certain cases like spinal cord stimulator implants, because it actually can help shift the curvature of the spine in a more favorable way to make the procedure safer. That said, you'd also use it for a microdiscectomy potentially and a laminectomy. But like I said, we don't do microdiscectomies here at Duke Spine or laminectomies. They're dangerous, outdated procedures that have a lot of collateral damage. All right, how are we doing? New cuff is lower, right? Or the blood pressure came down.
Yep.
What do you think?
Just gave him
I'm going to try to proceed because it came down, 15 points. But let's make sure we keep an eye on it. All right. Anybody know why it's important to make sure the blood pressure stays down? Huh? Well, we want to keep the blood pressure down because we don't want bleeding. All right, 5, 4, 3, 2, 1. We're doing 1, 2, 2, 3. I have a feeling we're going to be too high here. Let's just see. Shot? Yeah, I think we could be lower. A little bit, perhaps. Let's see. 4, 3, 2, 1. 1, 2, 2, 3. It's not bad, actually. Not bad at all. How you doing, my friend?
Okay. Try to keep your arms still.
Yeah.
And your head down.
You're doing great. You're doing really good.
Arms still. We're going to be asking you.
We're going to be just placing these needles and then we'll put you to sleep, okay? But everything's going real well. We just want everything as perfect as possible for you. Shot. Interesting. Hitting the facet. There we go. Let me know if you're having pain. You can feel your first herniation. All right, you're doing really good. I appreciate your patience. You're a patient patient. You like that? Huh? So can I ask you what you guys ended up doing yesterday? Shot. I didn't hear that. Was that, did you go to the zoo? Yep. How was it? I mean, AP.
You didn't see a lot of the lights.
Oh, you were hoping to see lions?
Yeah.
Oh, you know where you want to go for that is in Orlando. There's a Disney Animal Kingdom. Yeah. All right, so on the AP view, let's show the audience the T12 rib. You guys can see the bottom rib. T12, and that comes and connects to the pedicle of 12. Yep. Then the next pedicle down will be L1, and then it's got a transverse process right there. Yep. So we are at L1-2. That's where we expected to be. Let's go back to a lateral view. Excellent. So I'm just at the bottom of the L1-2 disc. You're doing great. Lay still, okay? Shot. I need about 1/2 millimeter. Shot. Shot. How many guys say that, right? Shot. At least Louise catches my humor. Shot. Shot. See, I'm happy with 1/2 millimeter extra. Little more numbing medicine. Just want to keep you comfortable. You doing all right? So we've got our first needle placed. You can call it a tracer. You can call it a guide. But the needle is just the beginning. And what comes afterwards is a guide wire, which goes down the shaft of the needle and enters the disc right where we want it to, exactly in the perfect spot. The perfect spot being where the tear in the disc is from the herniation. You doing okay? Yeah, you're going to feel it. There's no doubt about that. We can't stop you from feeling it, Sean. we're going to try to make it as comfortable as we can. But there's a limit to what can be done. Sean? You got a good bit of arthritis down here. Sean? Is that it? There's another millimeter. Everything okay? Sean? Again, I'm hitting the back of the vertebral body. Sean? Let's see if I can jiggle it in to where it needs to be. Us guys are good at jiggling, you know, jiggling things in. I mean, us guys as in the guys here in this operating room. We jiggle things in. Do you see the jiggling that I had to do? I'm not sure what term that is, but it's basically dancing the tip of the needle off of the bone and kind of like a little fish, you know, trying to get upstream like a salmon jiggling itself up the waterfall. Anyway, the Duke Spine Shuffle. How about the Duke Spine Jiggle? I'm going to give you some more numbing medicine, okay? You know, the nice thing about pioneering new technology and techniques is that you get to name them. You get to name them, you know? So we're going to name some things, and I kind of like jiggling because it's really, in my mind, that's what's happening. We're doing a little jiggling. All right. Great. So, not bad. Not bad at all. This is not bad for L3-4, L4-5. Should be okay. So let's go for it. Shot? Any questions?
Yes, we have two questions. This first one comes from Dizzy on YouTube.
Hello, Dizzy. Welcome to our live stream at Duke Spine.
They asked, how common is an 8-level fusion? I've never really heard anyone else with it. I've had that in my neck. It was to help me walk, which hasn't happened from 3 years ago. I also have a 2-level L4-5 fusion.
Well, Dizzy, I'm Dr. Duke Majan. Welcome to our broadcast. I can give you the answer that you might be more comfortable hearing, or I can give you the truth. Which do you prefer? The politically correct answer, or you want to know the real reason why it was done? So, I typically give people the truth, but I like to give people the option because sometimes the truth is so painful to hear. There's really no reason for it, except that it pays really well to the surgeon and the hospital and the company that makes the screws and rods that went into your neck. They make a lot of money. And my whole campaign is awareness about those surgeries being totally unnecessary. So if you came to Duke Spine, you wouldn't have gotten an 8-level fusion with screws and rods on your neck. You would have gotten the Duke laser disc repair, and we would have fixed a couple of discs, maybe 3 or 4 at most. And there would be no metal, no fusion, no hospital. And the thing about the walking is the walking problems in the neck come because the problem is hitting your spinal cord. So if it's a herniated disc, it's pushing on your spinal cord, causing balance issues. And that can be fixed 2 ways. One, with the surgery you had, which is a decompression infusion, I suspect. That's if they did it right, by the way. And I don't know if they did it right or not, but I'm assuming they did. And the other way to fix it is with the Duke laser disc repair.
She's getting the new bottle.
So, thank you. The problem is I'm seeing more and more spine surgeons that are now learning how to do fusions. They're being trained to do them at the universities, and they're doing them left and right. So just 20 years ago when I came out, only about 10% of spine surgeons knew how to do those types of fusions, including me. And I did them when it was appropriate. But now, in today's day and age, 20 years later, we don't need to be doing those fusions anymore. They do pay very well, and the surgeon makes a lot of money doing them. The hospital makes a lot more money doing them, and the company that makes those screws and rods, typically they get paid around, for those types of screws and rods, typically around $25,000, $30,000. And those screws and rods only cost them probably, I don't know, $300 to make. So the profit margins are massive on those screws and rods. And it drives them to promote that type of surgery to surgeons. So surgeons are now doing those surgeries even when they're not necessary, just because they make so much money doing them. The laser surgery that I would have done for you without screws, rods, or cages, or fusion, would have paid the surgeon about maybe $3,000 or $4,000. But the surgeon for your surgery probably billed $60,000 plus or minus, and probably made around $15,000, $20,000 easily. So you could see the pay difference is massive. And unfortunately, this is why we do our broadcasts. We're not interested in helping the surgeons get rich. I'm more interested in helping people avoid those types of surgeries that are unnecessary. That's what I do. That's why we do our broadcast. All right. So at this point, Dizzy, I'm very sorry that you're not doing better. The reason you're not doing better is probably either because the surgeon did not unpinch, your spinal cord properly, or because there was permanent damage already there. And I can't tell you which one it is, but I could tell you which one it is. If you did a virtual consultation, I will look at your new MRI and I will tell you if the surgeon fixed everything properly or they didn't unpinch your spinal cord. So the most likely reason you're still having problems, in my mind, is that the surgeon did not do the surgery well. Okay? But I can't tell you that for sure unless I could see the MRI after the surgery. And if you want me to look at it, I'm going to type right now, I'm going to have Henry type into the box a link that you or anybody could use to schedule a virtual consultation with me. And it is dukespine.com/VC, virtual consult. Okay? So I'd be happy to spend, some time virtually with you. You don't even have to come to our office. We do it over the internet. As a matter of fact, this patient right here traveled to us from
California.
all the way in sunny California, where I'm originally from, and he came to Florida for this surgery because nobody else in the world offered it. So we did a virtual consultation, this patient and I. Some pressure there? Just put some pressure on the skin edges. We did a virtual consultation first over the internet, and I made a diagnosis what was wrong with his discs and his back, and then he came here for the treatment. So you don't have to come to Duke Spine unless you're getting treatment, but you can do everything virtually through the internet, through Zoom. So go ahead and use the link that Henry typed up, dukespine.com/VC for virtual consult. And I'll be happy to look at your MRI, and I'll tell you exactly what I think was done, whether it was enough, whether it was done properly. Obviously the fusion is unnecessary, but a lot of doctors do it. It's not illegal. It's not currently below the standard of care, but it's something that it shouldn't be happening, in my opinion, especially since we have this endoscopic technology now. These surgeons just don't want to do it because it doesn't pay as well. and they don't know how to do it, so they're gonna have to go train. All right, so he has 4 discs that were damaged. They're herniated, pinching nerves, 2 of them on the left, 2 on the right. Are you comfortable?
Yeah.
Now, when I asked him, where do you get your back pain? He said this whole area here. So I was a bit, surprised, because most people have back pain typically just in the lower back, like down here, around the bottom 2 or 3 discs. But he had back pain diffusely. And when I saw him, the pain was doing better, but, it comes and goes. And at some point, it's just going to be more permanent. Are you comfortable?
Absolutely.
All right. He said, absolutely. Good. Wow, that just blew right out. Did you feel anything there? Yeah, so I didn't get any pressure at all. All the dye leaked out from the tear. That's how big the tear is. I couldn't even test that. That was L1 too. You can see it on the discogram, and you have to have a little bit of back pressure. It's actually sucking the dye in. You see that? It literally sucked it in. So I couldn't test L1. L1-2 is untestable due to large tear. That's how big the tear is there. Let's hope we can test this one. Anything?
I'm okay.
Huh?
I'm okay a little bit.
How bad is it on a scale of 1 to 10?
Maybe 4 or 5.
All right, so 5. Is that where you typically get back pain? Yeah, so that's where you typically gets pain. Again, the L2-3 that I just tested, the L2-3 disc, again, has a huge tear. The dye, basically, I had to inject the entire tube, which we never really do. We usually inject half of a tube. But it sucked the whole tube in, and it leaked out. So, but we got a 5 out of 10. And more importantly, it's concordant. Concordant meaning that it's his typical pain he gets every day. Is that better?
Yeah.
All right, we're almost done, and we're going to put you to sleep, okay? How bad is that on a scale of 1 to 10?
6, 7.
The highest it goes. The highest it went.
Maybe 6,
7.
7.
All right, so that was 3-4 was a 7 out of 10. Now I'm going to tell you that, see this here? There's residual dye in here, right? That's because I got good pressure and it stopped. It stopped leaking out. Basically, it filled the disc. Show us the disc that it filled. And you could see a giant tear in the back, right? There's the posterior annular tear. And there's the dye in the center of the disc we're showing you with the white arrow. Again, that's L3-4. Now, that one pressurized, and I could see his back arch up. I don't know if you guys saw that, huh? Stoic, yeah. So anyway, thank you. I appreciate that. I agree. But you could see when I injected, I didn't tell him I was injecting, his back came off the table because it hurt. And then I asked him how bad it was. He said it was a 6 or 7 out of 10. But that is his concordant typical pain that he gets. All right, we're almost done. Are you okay? Would you, Sarah?
Yeah.
Something on my forehead is bothering me, like a piece of hair or something by your
Oh,
finger.
I see it. I see it.
Can you pull
It's
it?
not attached to your head, is it?
It's probably
Oh my
attached.
god, I think it's attached.
Just pull it off.
I tucked it. Is that?
All right, yeah, that's fine. Thank you. I had one wisp of hair sticking out under my cap, and it was tickling me. I'm like, damn. Yeah, right? I understand. All right, are you okay? All right. How bad was that on a scale of 1 to 10?
That one hurt.
Give me a number. Highest number it went.
8,
9. All right, look at the dye coming back. You guys see that? Watch this. Watch this, Henry. I injected into the disc. Yes, there's a tear. All right, take a picture. Show us the tear. Go to the x-ray now, Henry. You see the tear at the back of the disc there?
Yes, we do.
All right, now watch the tube. Watch here, right? Can you see this tube here?
Yes, we can.
The syringe? Watch it. It's going to fill itself back up. Oh, it just did. Now it's not. Let's see. All right, well, it did before, but it's not now. So the dye just leaked out. But at least we got, what was it, a 9 out of 10?
Yes, sir.
9 over 10, okay? How long have you had back pain for? And that was concordant. 20 years?
20 years or more, yes.
So he's had lower back pain for 20 plus years.
Construction.
Yeah. And how long have you had the stuff going in your legs, the problems with your legs? Is that what finally brought you in? All right, we're going to put you to sleep, okay? I want you to count out loud for me from 1 to 100. Nice and loud, so we can all hear you. Count from 1 to 100 out loud. All right, so to summarize, we did our discograms. And the first disc, it just took all the dye. There was no back pressure whatsoever, so I couldn't get a reading on it. And that's because the tear is so big. The second disc, the tear was also big, but we got a little bit of pressure. He called that a 5 out of 10, and he said that was definitely where his pain comes from. Same thing with the next one, L3-4, and L4-5 was a 9 out of 10, okay? And that's also concordant. All of these were concordant. Concordant means typical pain. So that back pain will be gone, and his legs will be, the nerves will be decompressed that go down into his legs. The sciatica, weakness, numbness. All right, so this is going to be what? 2, 3?
Yes, sir.
All right, shot. So we're going to start at L2-3. Now, for those of you watching and doing surgery, you have to be careful at the higher levels. You have to be careful. The lower levels, L4-5, L5-S1, L3-4, those are pretty easy to do. But once you start getting higher up, you're getting closer to structures that you have to be very careful not to damage. So if you notice, my entry points higher are more medial, meaning towards the midline. So this is the midline. Medial means heading towards the midline. Lateral means away. My lateral incision, my further down incisions are more lateral. My further up incisions are more medial. There's a reason for that. It's about safety and not having problems, complications. I know we don't talk much about the entry points, but they're very important. All right, this is tight, so I need the 11 blade shot. Now as you're going in with your tubes, your dilator and tube, you've got to make sure that the guide wire, show us the guide wire, the tip of the guide wire. You guys see how the guide wire is skinnier than the needles? That's the tip. You don't want it to go much further than that. And if you're not careful, take a picture, I just pulled it back a little bit. If you're not careful, as you're putting your dilator in over the guide wire, you can actually get a little bit of soft tissue trapped between the tip of the dilator and the guide wire. And that will shove the guide wire forward. All right, so right now, let's see, shot. Okay, so right now we don't have anything trapping. We call that a cold weld. C-O-L-D, weld. W-E-L-D. We think of welding two pieces of metal together so that they stay together and they move together, right? But a cold weld is when you get soft tissue stuck between two pieces of metal that normally move with respect to each other, and now they're welded together. But they're not really welded like with a blowtorch. They're welded with just some soft tissue kind of getting in there and getting compressed between the surfaces so they can't move. Shot. All right, just about done. I can feel the herniation already. Any questions from the audience?
Yes, we have a question from Billy Jones on Facebook.
All right, before we do the question, I want to run the video on how does the Duke laser disc repair work? And then we'll get to some questions. So feel free to type up your questions. You guys see the guide wire move forward there, right? So we got to pull it back at this point. We're inside the disc. You can see the tip of the dilator. Show them the tip of the dilator is inside the annular tear and herniation. All right, so I've just shoved his herniation back into his disc, and now I'm going to go get it out, the pieces of it out with the endoscope, okay? The whole surgery is done through a 7mm tube. But let's go ahead and show the audience the video on how does the Duke laser disc repair lumbar actually work.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
All right, welcome back. As you can see, the Duke Laser Disc Repair uses new technology, endoscopic spine technology, to use a small incision, no damage to your body on the inside, and we go straight to the herniation and tear where all the pain comes from. We do what's called an annular debridement. We're removing the inflammatory tissue and the interposed nuclear material. This right here, we did a little bit of drawing. This is, you guys see the little happy face here?
Yes, we can.
That's Dr. Berndes. He said he's very happy, and notice the hairline. Why is Dr. Berndes so happy today? He's happy because two of his alma maters are in the Final Four. All right? Which are those two alma maters?
FAU, which is
Go Owls.
affectionately called Find Another University.
FAU, Find Another University.
And University of Miami, I went to med school.
There you go. So which one's going to win?
I think Miami's going to win.
He said Miami's going to win. All right.
I'm going with FAU.
Uh-oh. Uh-oh. Dissidents.
I'm from Boca, so I have to represent.
He said he's from Boca, so he has to represent. All right.
That was the stepping stone, got me where I wanted to go.
Well, let's not go to fisticuffs.
I'm fine with either or.
All right, so here we are inside the tube. And we're actually, this tube right here, for those of you that are watching, the end of the tube, you guys see where the metal ends right over there to the side? That literally is sitting inside the tear, the annular tear. And these white things are part of the annular tear. They're the annulus that's frayed. This right here is part of the herniation that was sticking out, pushing on his nerves. And now I'm going to use my laser to remove it. So, for those of you wondering about this technology, it's called the Duke Laser Disc Repair. It's a type of surgery that was developed 16 years ago, around 2006. And I developed this technique after learning about endoscopic spine surgery from basically spine surgeons from around the world, specifically the United States, Korea, South Korea, not North Korea, and Germany, England. There was one surgeon in England who was doing some endoscopic work, but none of them were using the laser. The laser is my addition to this technique. And since then, people are now using the laser after watching my surgeries and learning how to do it. And they're copying my technique, which is fine. The technique that was developed at Duke Spine Institute. They're copying it for one reason, because it works. And it literally is the very best technique in the world. Here's a herniation. All right, let's get this on camera. Lights on, lights on.
Please.
Here it comes. Move your hand. Bring out the tape measure. Woo, it's a good size one. Oh yeah, mama. You guys hear that suction? All right, can you see this?
Yes, we can.
Can you bring this thing sideways, other way? Yes. That is a biggie. Look at that thing. Can you guys see the tape measure?
Yes, we can.
That is one piece of herniation. And remember, I shoved the dilator through the tear at the beginning and hammered it in there, and it literally pushed this piece of herniation from where it was sitting on the nerve back into through the tear where I could safely take it out. Okay? And it's got some blue color on it because it's degenerated nucleus pulposus that stains blue with the Duke spine dye. But it's over a centimeter long. I'll deliver it. Let's give it an APGAR score. Smack its little booty, get it to cry. All right, back on the scope, lights off, back to work. I need to turn the irrigation back on so we can actually see. All right, then there's a few more pieces. We're going to take them out over time, probably a few stuck behind the tube. So I'm going to bring the laser back in, but a lot of people say the laser is not necessary for spine surgery. Those are people who don't use lasers. How would they ever know that? That's crazy. The laser is absolutely essential to this surgery. Cannot be done, the surgery cannot be done without a laser. The problem is, folks, that spine surgeons are not trained to use lasers. They don't know how to use a laser. Okay? So only a few of us know how to use a laser. And lasers are expensive. And the training for lasers, you can't get trained. It's very hard to get trained on a laser. I was trained 16, 17 years ago. So doctors don't know where to go to get trained on a laser. Now, if you're a urologist, you're going to be trained on a laser. But that's laser being used for kidneys, kidney stones, and prostates. Okay, they use the laser to take out prostate tumors. So they're trained on the laser for urology. But urologists don't do spine surgery. Spine surgeons do. At least they're not supposed to. And spine surgeons are not trained on lasers. So the fact that they're publishing papers and opinions about lasers in spine surgery, it's only because they're afraid of this technology, that it's actually going to be taking over all of spine surgery, which it is. And they're not going to be part of it because they basically never bothered to get trained on it. Now myself, I'm trained on all forms of spine surgery, from artificial discs to fusions to laminectomies, microdiscectomies, the mild procedure, interspinous devices, spinal cord stimulators, morphine pumps, you name it, I've done it. And that's because I went to the best neurosurgery training program of my time, which was University of Florida in Gainesville. Okay, top neurosurgery training program in the world back in the late 90s. Okay, that's changed now. I wouldn't go there today if I was back deciding where to go. You have to understand there were only 110 neurosurgery training programs in the United States back in the 90s. And each one of them took one resident, one trainee every year for 7 years of training. So once you entered the program, you had 7 years until you were done. 7 years to learn how to be a neurosurgeon from their professors that worked there at that university. So university neurosurgery training programs were basically ranked based on which ones had the best training. And the University of Florida in Gainesville was ranked #1 by the one person who would know the most about neurosurgery training programs in the 90s. That was Dr. Marty Weiss. He was the chairman of neurosurgery at USC in Los Angeles, University of Southern California, which, by the way, USC itself was a top program, but not #1. And Dr. Weiss was my mentor. He was also the chairman of the Neurosurgery Residency Review Committee, the committee that went around the United States and basically made sure that all the neurosurgery training programs were doing a good job of training the residents to become neurosurgeons, that learning how to do the surgeries they needed to learn how to do. Okay? You can't have a training program that doesn't do neurosurgery. You can't have a neurosurgery training program that doesn't do enough neurosurgery, the right types of neurosurgery. So their job was to assess how good training was at each neurosurgery training program, and he was the chairman of that committee. And you imagine that was a very select group of people. But anyway, he was also my mentor, and his opinion was that Gainesville, Dr. Roten's program at the time, was the very best in the world. It's the only program that he ranked as an A+. And when he was advising me, he told me, you should go there for your training. That's my top choice for you. So I went. And I was trained on all the most advanced technologies in neurosurgery. But we were not doing endoscopic surgery because it was so new at the time. It was being done in Korea. It was being done in Germany by one surgeon. It was being done in England by one surgeon. And those surgeons came together to train me, basically, and a couple of other surgeons on the technology. And they all did the surgery differently. They didn't do it the same, okay? Their approach was different. Their exposures were different. Even the instruments they used were different. But the very best instruments, the very best technique I took away from those doctors. And I brought it to the United States, and I applied it in my practice 16 years ago, back in 2006, 2007. So we've been doing endoscopic surgery for 16 years, and now we've treated over 1,600 patients with this surgery. I've done far more than that with fusions. Okay, I've done over 2,500 fusions in my career, and artificial discs. Of course, laminectomies, discectomies. So I have the benefit of trying all these different surgeries in my experience, and not just trying these surgeries, but learning from the very best surgeons in the business at the academic centers. So when it comes to my judgment about what's best, I have that experience to draw upon to be able to make a determination of what's best for my patients. And there's no surgery that I can't do on the spine. So I think about, there's another piece of herniation, by the way, in case you're wondering. It's probably the last one we're going to see here. But I'm not limited in what I can do like other surgeons are based on their training. Other surgeons may have learned one or two things. I've learned all the surgeries. And that's because I made sure to go to the best program I could possibly go to based on my options that were available. All right, we are done here. You see a little bit of fat right there in the epidural space. A little vein right there to the right. Cute little vein. It's part of Batson's plexus. But you can see where the herniation was in that gap right there, and it's gone. So I'm happy with those results. And we're going to move on to the next disc. Now I know we have some questions, so Henry, if you want to ask me some questions while I'm working here, that's fine.
Of course. This next question comes from Billy Jones on Facebook. And they asked, so briefly, when is a patient not a good candidate for the DLDR, in the cervical spine, that is?
When is a patient not a good candidate for the DLDR in the cervical spine? When the patient has severe deformity, severe deformity. And those deformities are severe kyphosis, severe scoliosis, severe listhesis, which is a slippage, but that's almost never that I see that. I would say out of every 100 patients with a cervical spine problem, at most one person is not a candidate. Now, there are other conditions. So remember, just to back up, we're talking about degenerative spine conditions, okay? There are other spine conditions that are not treatable with the Duke laser disc repair. So you have tumors, you have fractures, and you have infections, and then you have degenerative conditions. Now, if you take 100 people with cervical spine problems, 95% of them, their problem is degenerative, not tumor, not fracture, not infection, okay? But if you include the tumors, the fractures, and the infections, then I would say 95% of patients are candidates. But the truth is, tumors, fractures, and infections, they go to the emergency room at the hospital, and they get usually appropriate care done at the hospital, which is open surgery with or without decompression, instrumentation, and realignment. Those are not patients I'm talking about. So if you're watching the surgery and you're in the emergency room and you just had a car accident and you broke your neck, this is not the surgery for you. This is for people with neck pain, back pain, that have a degenerated disc or a herniated disc or a bulging disc or a ruptured disc, protruded disc, spinal stenosis. Hey, we're going north. Okay, so this is for the most common problems affecting the spine, which are degenerative conditions, which is what you have, by the way, I'm sure. Unless you have a tumor that we don't know about. Shot. All right, now we're working on L1-2 shot. All right, there's the guide wire. It's sitting in that white little spot there. I got to leave it, take the needle out. We're going to go through the same incision. It's a 7mm incision. What I've done is I've kept the same entry point, but I've changed the target or trajectory. How are we doing, doctor? He's doing all right? He's not doing anything back here. Yeah, he's looking good to me. Shot. So far, he's doing very well. So I hope I answered your question. But basically, break down the spine problems in the neck into degenerative, which is about 95% of all spine problems in the neck, and non-degenerative, which is your tumors, fractures, infections, and fractures like trauma, okay, car accidents, high-speed MBAs, falls. Okay. So as long as you have a degenerative condition, you're a candidate for Duke laser disc repair, with small exceptions. Exceptions being, for example, severe scoliosis, where the bones are twisting so much on each other, then maybe you're not a candidate. But, it's easy, folks, to find out if you're a candidate. We make it so easy. Use the link below, dukespine.com/VC.